I'm Dr. Sanjeev Jasuja, Senior Consultant Nephrologist at Indraprastha Apollo Hospital. Firstly, I'm grateful to Dr. P.C. Reddy, founder Capio, Dr. Anupam Sagar, current president of Capio, and my dear friend and the great organizer, Dr. Tandon, for giving me this opportunity. In this session of kidney disease, we have three globally acclaimed speakers of Indian origin with a specific performance in their respective fields. We have three talks in this. First talk is what is new in acute kidney injury. Second talk is about the first talk will be delivered by Professor Ravindra L. Mehta, and this session will be chaired by Dr. G.S. Garewal, a champion in elder care, and he is going to be president of IMA Delhi State for year 2021. Second talk will be delivered by Professor Suvo Roy, and this session would be chaired by Professor Sunil Patel from Canada. He's president of Canadian Association of Physicians of Indian Heritage, CAPI, and a former president of Canadian Medical Association. And the third talk would be delivered by Professor Sandeep Guleria regarding what is new to recruit more donors and to deliver a good quality kidney transplants. For that, this particular talk, we have a chairperson, Dr. Jacob Thomas from Malaysia. He's president of Association of Private Hospitals in Malaysia and is also associated with various quality initiatives by the government of Malaysia. Before we proceed further, I have for my audience a suggestion. In case if you have any questions, put them in the chat box. We'll make sure that you get your due replies on your email within the next 7 days. Do mention your email in your chat box also. Thank you. And with this, I would like to invite our first chairperson, Dr. G.S. Garewal, to invite our first speaker. Please proceed, Dr. Garewal.
Good evening, namaskar, greetings from Dr. G.S. Garewal to all the delegates, distinguished faculty of the Capio International Conference. It's a matter of great pride and privilege for me to have been invited for this phenomenal conference. I thank Professor Jasuja to have invited me to chair the session on nephrology. It is now my great privilege to invite the distinguished speaker for the next session, none other than Professor Ravindra Mehta. Professor Mehta is a professor emeritus of medicine at the University of California, San Diego, where he directs the USCO Masters in Clinical Research program and is the site principal investigator of the NIH-funded UAB USC D. O'Brien Center for Acute Kidney Injury Research. Dr. Mehta is an internationally recognized expert in the field of acute kidney injury and continuous medical replacement therapies. I'm sure Dr. Mehta's presentation will go a long way in updating the delegates in the field of kidney injury. I now welcome the speaker, Professor Ravindra Mehta. Thank you.
Thank you for the opportunity to present to the Global Indian Physicians Congress. My name is Ravi Mehta. I'm a professor of medicine at the University of California, San Diego. And my topic today is what's new in acute kidney injury. Over the last several years, we have had a significant improvement in the definition and classification of acute kidney injury, as is shown in this slide. And I will refer to some of the changes which have occurred over the last 3 to 5 years, particularly with the involvement of biomarkers. When you think about acute kidney injury, we now know that it is highly prevalent. And as you can see from this slide, all over the world, the incidence is as much as about, incidence and prevalence is as much as about 20%, although we don't have as good information from Africa in general. What I'd like to do in the next several minutes is cover these 5 areas which represent where the changes are, and in addition, describe what's happening in the research field for this. So first, with respect to risk for acute kidney injury, the more important thing that we recognize now is that there are contrasting characteristics of how it occurs in the world, with differences between high-income countries and low to middle-income countries. And as you can see, these are differences both with respect to the environment and the diseases that cause acute kidney injury, but also how they are managed. And what we've come to realize is that AKI is a syndrome and not really a disease per se. For example, we know that the inherent and etiological risk factors for acute kidney injury across the world include dehydration, hypertension, and shock. And this is regardless of where the injury is encountered. And in addition, what we find is that the pathophysiology has been looked at considerably. Where, as you can see, it is fairly complex, but we do know what the mechanisms and pathways are undergoing across the board. What's important to recognize, though, is that these risk factors are also associated with disease modifiers which influence the outcomes. And these outcomes can be both with respect to the events on the kidney itself, but also other events such as cardiovascular events. And what's more important here is we recognize is that acute kidney injury, in terms of how and when it transpires, has different courses. And what we're seeing more and more is that we are recognizing community settings and hospital setting acute kidney injury have different outcomes as shown here. And more importantly, this mortality and outcome is related to the severity, but is different for community versus hospital acquired. In COVID-19, this is representative of some of the most recent information we have. And one of the things we're finding is it is process of care oriented. So the potential risk factors for COVID-19, as you can see here, are demonstrated in this part here. And when we look at the overall next step in terms of recognition, what is more important is we have more information now on acute kidney injury biomarkers representing damage biomarkers. And we have started to recognize that a combination of damage and functional biomarkers together will give us a better information on how to manage these patients going forward. In fact, as a consequence of that, we have suggested as part of an ADKI consensus conference published earlier this year that there should be a new definition of acute kidney injury which incorporates the biomarker positive or negative states. And as a consequence of this, we will be able to determine where the patient is in the course of disease and therefore optimize treatment itself. Now, moving on to the response for acute kidney injury and the management strategies here, what we are recognizing more and more is that there is an opportunity to put it into an AKI care bundle to combine a variety of different approaches together in this setting. And this improvement in all outcomes associated with the implementation of bundle is demonstrated in this study published some 2-3 years ago, showing you that in a group in the UK, you could reduce the length of stay. You could also reduce the case fatality rates in these patients as such. And more recently, this has been combined with biomarker enhancement in a study which was done in cardiac surgery, where patients underwent an initial stratification based upon their response to a nephrocheck biomarker and undergoing cardiac surgery, and showed that the element of applying the CT surgery bundle reduced the risk of acute kidney injury in these patients. What about renal support? This is obviously an area of interest to all critical care physicians and nephrologists. And the focus in the last few years has been in terms of looking at the timing of dialysis. There are 4 studies which have been presented. The first one, a single center study, had shown a difference in mortality with an early dialysis started at KD goes stage 2, and versus that started at a later point. However, subsequent studies in the Akiki and the IDEAL trial, this based upon from multiple centers in France, in all comers in the ICU, and this based upon septic ICU patients again in France. Both of these studies showed that a delayed initiation actually had no difference versus early with respect to the primary outcome. However, those patients who were in the delayed category had a significant number of patients not requiring dialysis. The most recent study published earlier this year, the START-AKI trial, again about 3,000 patients in multiple centers across the world, again showed no difference in the mortality as such, but showed that the accelerated strategy had a higher chance of some renal replacement dependence after the event. So in general, what we are finding now is that deferring dialysis until complications may avoid it in some patients. However, we do not really have any current reliable tools to predict who needs it and when it should be really started. And as a further aspect of this, from the COVID-19 data set this year, we have recognized this is a very nice study published earlier here from 67 hospitals. And as you can see, is the risk factors for acute kidney injury are quite similar to that for COVID-19 with respect to hypertension, diabetes, and high BMI. And in addition, with respect to what was going on in the underlying severity of disease. But what's more interesting and somewhat sobering is that a significant number of patients requiring dialysis died within the hospital itself. Finally, with respect to rehabilitation, this is an area which is really becoming very important and pertinent for us. We know now that if you can detect acute kidney injury earlier with the biomarkers that I mentioned to you earlier, we have recognized that their recovery patterns have a clear relationship to downstream outcomes. Those patients who do not reverse early have a worse outcome downstream. And in these patients, they may end up with organ death on dialysis or overall mortality itself. And even those who do recover may not have complete recovery in that setting. So as a consequence, what we are recognizing more and more is the long-term consequences of acute kidney injury are associated with long-term disabilities. They're associated with a lot of cost and also with mortality. So if we are to make a change, we have to think about acute kidney injury as a continuum, and both from a side from the community all the way to management in the hospital, and then a follow-up later on. And as a reflection of this, we have provided some guidelines and some recommendations from an ADKI consensus conference, which suggests that the post-AKI care should be protocolized and should also be based upon not only the nephrologists providing the care, but non-nephrology care providers following certain protocols itself so that we can manage this disease as it comes along. Finally, with respect to research, this is an area which is very fruitful. As an example, we now have information showing that artificial intelligence applied to electronic medical records, large data sets, this is from the Google DeepMind study published earlier, shows that you could have the opportunity to predict who's going to develop acute kidney injury, who's going to need dialysis, and who's going to need dialysis within 90 days. However, the difficulty still is that there is a significant amount of false positive alerts in this setting as such. What's more interesting, though, is the concept that how do we determine how to change the heterogeneity of these patients? Because when you look at the whole group of acute kidney injury patients, we need to be able to find those patients who will have a low mortality risk versus with a high mortality risk. And then within these, figure out which is the pathway which could be targeted so that these patients have the best benefit. Towards that end, there is a variety of different techniques which have been thought about, but this is one study from Dr. Bhatraju, the University of Washington, showing that you could look at biomarkers of angiotensin 2, angiotensin 1 ratio, and soluble TNF receptor 1 to show that these pathways can be implicated, and based upon these pathways, there is a relationship with respect to these subphenotypes in terms of what happens with respect to hospital mortality. So this is one area which is coming across. And in a second aspect of this is, again, based upon these specific biological mechanisms, for example, mitochondrial dysfunction. Dr. Sarmir Parekh from Boston has shown that you could use nicotinamide, vitamin B3, in a small pilot study to show that this causes improvement in patients who are undergoing cardiac surgery with respect to improvement from development of acute kidney injury. So what's new in acute kidney injury? We have new diagnostic criteria for AKI. We have care bundle-based management. We have quality metrics for AKI care and AI tools for prediction and alerts, and then subphenotypes for targeted interventions. So it's been an exciting time, and we look forward to many more of these approaches developing in the future. I'd like to invite you all also to participate in our next conference, which will cover more of these topics in the advances in acute kidney injury. And you can find details on this website at crtonline.com. Thank you very much.
Thank you, Professor Ravi. You have given an excellent overview of our understanding about acute kidney injury till date and what's going to be in the future. And with that, I also thank our learned chairperson, Dr. J.S. Garewal. With this, I'll conclude this session, and I would like to invite the next chairperson, Dr. Sunil Patel, to introduce Dr. Suvaroy and proceed with the proceedings of next session. Thank you.
Thank you, Dr. Sanjeev Yasuja, moderator of this session, and for his kind words in introducing me, for inviting me to introduce a very renowned speaker, Dr. Shuva Roy from the United States of America. I'm also very thankful and grateful to the GAPYO Organizing Committee and this opportunity to chair the session during this Global Indian Physicians Congress. Dr. Shuva Roy did his PhD in electrical engineering and applied physics at the Case Western Research University in 2001 after doing his MS in 1995. Dr. Roy is a professor at the Department of Bioengineering, Therapeutic Sciences, and Surgery at UCSF Schools of Medicine in California. Dr. Roy is an engineering lead in Surgical Innovations Program and director of the Biodesign Laboratory, faculty director at UC Berkeley, Master of Transitional Medicine Program, and technical director of the Kidney Project, which is a national research and development effort to create a small, surgically implanted and freestanding bio-artificial kidney to treat an end-stage renal disease. Prior to joining UCSF in 2008, Dr. Roy was a co-director of the Biomeds Laboratory in the Department of Biomedical Engineering at the Cleveland Clinic in Cleveland, Ohio. Dr. Roy is the recipient of a Top 40 Under 40 award by Crane's Cleveland Business in 1999 and also received the Clinical Translation Award at BioMEMS and Biomedical Nanotechnology meeting. Dr. Roy was selected as a recipient of the TR100, which features the world's 100 top young innovators as selected by Technology Review, the Massachusetts Institute of Technology in the USA. He was also presented with a NASA Group Achievement Award for his work on harsh environmental MEMS microelectromechanical systems. I would now like to invite Dr. Shuva Roy to deliver his talk.
Hello, it's a pleasure to be here. First of all, my esteemed thanks to Dr. Jasuja and Dr. Patel for this session. I also want to thank Dr. Tandon for inviting me on the behalf of the community to present at the Global Indian Physicians Congress. Today, I will talk about breakthroughs in the management of chronic renal failure, and I will highlight a very specific project I am involved in, which is the development of an implantable artificial kidney. I am Shuva Roy. I'm at UC San Francisco, and this project is a team effort that involves a number of research and development groups across North America for now, and hopefully collaborators worldwide in the future. Let me start off with a quick recap on the prevalence of end-stage renal disease in the United States, where there are almost 750,000 patients with kidney failure that have to be treated by dialysis or transplant. Worldwide, this number is over 3 million and is growing fast, not only in the United States, but all over the world. And in countries like India, with the recent surge numbers in diabetes and hypertension, the challenge of ESRD will be felt for some time to come. Looking at this graph, you'll notice that the vast majority of ESRD patients in the United States and the developing world are treated by dialysis, and only a few are treated by transplant. The statistics are such that there are over 100,000 patients on the transplant wait list in the United States, but less than 20,000 patients get a transplant each year. So clearly, with the increase in chronic kidney failure, the solutions of hemodialysis continues to be relied on. Unfortunately, hemodialysis has a number of challenges, both in terms of patient outcomes, access, and cost. So the approach we are taking is to find a third way. A third way being an implantable bioartificial kidney that will provide the benefits of a transplant organ while overcoming the scarcity of donors and remove the challenges that dialysis patients face. So in this picture, I illustrate what the implantable bioartificial kidney is. It's a surgically implanted device that combines a mechanical ultrafiltration unit to remove toxins from blood with a cell therapy unit that provides the other metabolic functions of the native healthy kidney. The device can be instrumented with sensors to provide the patient, their family, and the physician and status of the device, but also the condition of the patient. After surgical implantation, the patient is able to experience continuous treatment, is not encumbered by the need to go to a dialysis clinic, and because the device is fully implanted, there is less likelihood of infection that happens in typical dialysis when the access site is a route for infection. And because we provide both cell therapy, recapitulating the tubule, with ultrafiltration, recapitulating the glomerulus, and do this continuously, will provide more physiological therapy, leading to better patient outcomes. And by keeping the cells encased in the bioreactor, isolated from the patient's immune system, we will be able to avoid the need for immunosuppression drugs. So this work is built on some pioneering foundations that was based at the University of Michigan in the United States. Dr. David Humes looked at how to recapitulate a kidney function for patients suffering from acute kidney injury with sepsis. And he showed that by combining ultrafiltration and cell therapy, you are able to provide a survival and health benefit that dialysis simply could not. So what you see on the right is actually the architecture of the system he called the renal assist device. And on the left is Dr. Humes holding the cell therapy component, the bioreactor that has the kidney cells. So here is a photograph of the actual system in the intensive care unit in Michigan. You'll notice that it consists of two standard dialyzer systems, lots of tubing, lots of pumps, and there are two key components, the hemofilter, which is the mechanical ultrafiltration unit to the right, and the bioreactor that houses the cells. In a series of preclinical studies, he was able to show the therapeutic benefit of this device, and he was then approved to conduct clinical trials. And in phase 1 and phase 2A clinical trials, the RAD device, the renal assist device, showed a 50% mortality reduction in the treatment arm relative to the control arm, which was standard of care, continuous renal replacement therapy without cells. And this dramatic survival benefit was directly attributable to the cells in the bioreactor. What is exciting about this work was not only the clinical experience of the physicians and the patients who benefited, but this was the very first time that cell therapy for kidney failure had actually been tested on patients from a regulatory perspective, meaning the FDA. To date, no other cell therapy has made it to clinical trials for kidney failure in the USA like Dr. Humes has done almost 2 decades ago. So, what is the key question? So the key question for us is, how can we take this exciting data set and the exciting development of the renal assist device, and which was tested on acute kidney injury patients in the ICU, to the vast majority of chronic kidney failure patients who have to rely on dialysis 2 to 4 times a week, 3 to 4 hours per session. And as we all know, dialysis is fraught with complications of infection, poor outcomes, such as a cardiovascular disease, bone dysfunction, and the like. However, so if we could miniaturize the renal assist device and apply it to this constituency, we might have a way to provide the benefits of the RAD to the larger dialysis and end-stage renal failure community, while avoiding the shortcomings that are associated with dialysis, and also overcoming the challenges of transplant, which requires immunosuppression drugs. Well, to do that, we decided to look at the fundamental workhorse of a dialysis system, and that is the dialyzer. And what I show here is that over the last 50, 60 years, there has been very little change in the actual technology of the dialyzer. It's a hollow fiber system constructed from polymers, and today it's still very much the same. And the system around it to pump blood, to pump dialysis solution, it requires a lot of energy, meaning pumps, lots of tubing, requires lots of surface area, and therefore one place we thought we might be able to attack the challenge of miniaturization of the renal assist device is by coming up with a dialyzer that is better than the current dialyzers today. The current dialyzers are based on polymer hollow fiber membranes. So we decided to make a new membrane, which we call silicon nanopore membranes, SNM. These membranes are made using semiconductor manufacturing technology, the same technology to take silicon wafers and make electronics, the electronics that you have in your iPhone, in your TV, in your camera, and the like. But because of the precision manufacturing capabilities of semiconductor manufacturing and the ability to control costs, it is possible to make a membrane that is highly precise in geometry, highly permeable, and very biocompatible. What you see on the left is a silicon wafer, and on the right, you see scanning electron micrographs, top view and cross-section views of a single silicon nanopore membrane wafer. This membrane is only about half micron thick. A typical polymer membrane is over 30 microns thick. The polymer membranes have a tortuous path that leads to inefficient filtration. This has a highly parallel pore geometry that leads to a highly efficient filtration with high selectivity. And by modifying the silicon surface using self-assembled chemistries, you can make them very biologically friendly so they don't react adversely to blood. So using this technology, we proceeded to build the mechanical component of our artificial kidney, the hemofilter. Here you see a photograph of a prototype hemofilter. Inside the hemofilter are silicon membranes that are layered one on top of each other. And as you can see on the bottom left, blood flows in a fashion over the membranes through the device. And you can use the membrane to collect the ultrafiltrate. And because the silicon membranes are so efficient and they're arranged in a parallel stack, you actually do not need electrical pumps or battery power. Just the pressure of the heart in the patient is sufficient to drive blood and generate ultrafiltrate. In fact, we have taken this prototype device and shown that we can do dialysis with this device to establish its potential for clearance. So in this particular experiment, we implanted the filter, attached it with permanent blood connections, and then on the opposite side, using a connection to outside of the animal, we're able to do dialysis. This is shown here on the left-hand side. You can see the animal with its dialysis catheters sticking out of the abdomen, which are connected to a pump to circulate dialysate. There was no external blood circuit. We did not apply anticoagulation, and the blood flowed through the device without the need for electrical power or batteries. And what you see on the right-hand side is in our very first experiment, over the course of 3 days, we were able to remove urea and creatinine, and we did not lose albumin. There was a little bit of a drop in urea and creatinine rates at the last day. We suspect that may be due to equilibrium establishment in the blood and dialysate, or it could be because of some initial boundary layer formation. This is under further study. But nonetheless, what we've been able to show is implanted ultrafiltration and implanted clearance via dialysis without the need for pumps or systemic anticoagulation or the need for needles. Next, we looked at the bioreactor that houses the cell. Here you're seeing a picture on the left, illustration of the prototype bioreactor that housed human renal tubule cells that are isolated from a cadaver kidney not suitable for transplant. These were plated onto cell inserts, and then they're loaded into the bioreactor, which is shown on the right. And as you can see, it is connected to the blood vessels through an inflow graft and an outflow graft. And this was implanted again for 3 days in the neck of the pig. Again, without the need for pumps, blood flowed through the device. We did not administer anticoagulation. And we also avoided using immunosuppression. And in this very first experiment, we're able to show after 3 days, the cells in the device were still viable. The blood flow path was patent, no thrombi. And the pig in this case and the previous case did not exhibit any adverse reactions. So based on this exciting data, we took the cells from the device that had been explanted and characterized their performance for damage using 2 well-established markers, NAG and GGT. These look at the damage to the cells and indicate the likelihood of rejection. And we did this experiment where we compared cells from the device with cells that were left outside of the animal, which we call the negative control, and then a positive control where we exposed immunogenic molecules to cells outside, and that's the positive control. You'll notice in both cases that the positive control damage, as evidenced by the relative expression, is much higher than the implanted cells. And the implanted cells behaved almost as well as the negative controls that did not get exposed to the animal or the molecules that are immunogenic. So this to us confirmed that we have a bioreactor that is capable of immunoprotection and presumably can provide the metabolic functions of the renal tubule. So put together, we've been able to show that we have a hemofilter that works without the need for mechanical pumps and systemic anticoagulation, and couple that with a bioreactor that does not require immunosuppression. So this work is now forming the foundation for subsequent scale-up of the device and then eventual preclinical work and the first human trials in the coming years. Let me end by making a note of my appreciation for the various agencies that have supported our work, both federal government and private foundations, and the rest of the kidney project team that draws from a team of engineers, physicians, patients, and entrepreneurs who want to change the face of kidney failure and its treatment. Thank you very much. I appreciate the opportunity.
Dr. Roy, I must compliment for your innovation, which is going to change the caregiving scenario of the chronic kidney disease across the globe once it sees the light. And I would also like to thank Dr. Sunil Patel for conducting a wonderful session. With this, we close this session and move to our third session, which is the last. I'd like to invite Professor Jacob Thomas from Malaysia to introduce our learned speaker and proceed.
Thank you to the moderator of this session, Professor Sanjeev Jasuja, and for that very kind introduction. It's my great honor and pleasure now to introduce the third speaker for this session on nephrology, Professor Sandeep Guleria. Now, let me give a short introduction to Professor Sandeep Guleria. He is a Fellow of the Royal College of Surgeons of England, of Edinburgh, of Glasgow, the list goes on, and currently a senior consultant renal transplant surgeon at the Indraprastha Apollo Hospital in New Delhi, and leads one of the busiest renal transplant programs in the world. Professor Guleria obtained his master's in surgery from the All India Institute of Medical Sciences in New Delhi and trained further in transplantation in the United Kingdom. Dr. Guleria is credited with having done the first 2 successful kidney transplant or kidney pancreas transplants in the Indian subcontinent and has set up programs in Nepal, Almaty, Dehradun, Ludhiana, and Guwahati. He has been the past secretary and past president of the Indian Society of Organ Transplantation. Dr. Guleria was awarded the Distinguished Luminary Award by the Indian Medical Association in 2007 and Exemplary Contribution Award in 2008. He has published more than 128 index papers and has 12 chapters in books and been honored with 6 orations. In 2018, in recognition of his services to organ transplantation, he was awarded the prestigious Padma Shri Award, the 4th highest civilian award bestowed by the government of India. Ladies and gentlemen, please join me in welcoming Professor Dr. Sandeep Guleria to deliver his talk.
Hello, I am Dr. Sandeep Guleria. I'm a senior consultant surgeon at the Apollo Hospital, and I'd like to thank Gapio for this opportunity. I'd like to thank Dr. Jacob Thomas and Dr. Sanjeev Jasuja, a very close friend who's moderating this presentation. I will briefly be talking about what's new in kidney transplantation. I think it's important to remember that over the past decade, the number of standard criteria donor transplants, as well as the expanded criteria donors, as well as the donors after cardiac death, have grown. So the number of donations actually have grown over the last decade. However, the survivals have not changed that much as we would have liked them to change over the years. I think it's important to remember that the last decade essentially belongs to advances in surgery, advances in medicines, and in advances in monitoring our grafts better. The use of molecular techniques, as well as we now being able to easily overcome the blood group barrier, critical sensitization, prevent the development of anti-HLA antibodies, treat chronic active antibody mediated rejection, and reduce non-immunological complications following kidney transplantation. One of the good things that has happened during the COVID era is the utilization of telemedicine, providing benefits of reaching out to kidney transplant patients and being able to monitor and advise them when physical contact has become very, very difficult. So the recent advances that we shall focus on are cardiovascular diseases in kidney transplant, kidney allocations, kidney exchange strategies for immunosuppressive minimization, neuroimmunosuppressive drugs, the changing landscape of anti-HLA antibodies, pre-existing diabetes, infections, hyperparathyroidism, COVID and its impact on kidney transplantation. One of the few things that we have learned is that there is no doubt that if you have renal failure, the best treatment for you is a transplant. And that is why the waiting list for patients who want a transplant has grown. We are now accepting donors who would have multiple abnormalities like multiple renal arteries, donors who would be very aged but who had a good GFR, and these would be as marginal donors who we thought could qualify by giving a kidney to someone they love. Even donors who have arterial aneurysms, because now bench surgery and good vascular techniques make the use of these kidneys possible. Managing donors with stones, where we take out the stone at the time of surgery. This is our own work. Using a donor who has a horseshoe kidney, dividing the isthmus, and then taking out one part of the horseshoe kidney and transplanting it into a recipient. These are all advancements that have been fueled by our desire to give our patients the very best and encouraged by the fact that we have got considerable experience now in looking after these patients and have developed over the years considerable innovative techniques to look after them. Dual transplants is another thing. With the advent of cadaver transplants and more children coming up as cadaver donors, taking both the kidneys from a child and transplanting them into an adult. The use of non-invasive techniques like stents in situations where earlier we would be going in and operating. This is our patient who had a renal artery kinking, and as you can notice, the cardiologist has gone in and has stented the kink so that we no longer needed to go in to clear out the stent. Renal graft ruptures, there was a time we would be thinking of taking out these kidneys, but over the years we have changed. We now repair them, especially with Surgicel and by the use of new hemostatic devices. Pediatric transplantation has come of age. It is quite routine now to offer children pediatric transplantation. One of the big advancements has been liver and kidney transplantation, especially in oxalosis. This is a young child who's got oxalosis. One sister has given him the liver, the other sister has given him the kidney, and this boy has gone back to lead an absolutely normal life. One of my favorite patients is baby Saroy, who underwent both a liver and a kidney transplant. all possible because of excellent expertise that we have gained in the surgical field, learning to split the liver, learning to manage a child on dialysis, and subsequently transplanting him with his father's kidney. Of course, what has happened over the last few years also is that we have realized the benefits of kidney exchange strategies, and we have decided that paired donations allow us to overcome ABO and HLA incompatible transplantation by swapping organ donors. These paired donation programs could include other parameters that influence graft outcomes, such as viral infections or age disparity, which means you could use a hepatitis C donor for a hepatitis C positive recipient. There is a considerable amount of work being done to develop these programs all across the world and see if there could be a globally paired organ donor program. This is what it is. This is a swap transplant. This is a swap transplant at the very basic, which means A gives to C and B gives to D. However, currently now you have very large paired organ chains that can extend up to 4 to 10 people being transplanted at the same time or in the next 1 or 2 days, so that the organ is transplanted into somebody who we feel has less antibodies and has the largest chance for surviving for a very long time, which means improved graft survival and improved patient survival. There has been a considerable improvement in us being able to do ABO incompatible transplants, the use of plasmapheresis, the use of the glycosorb filter, and we would currently take patients who had fairly high anti-A or anti-B titers, and we could get down these titers by the use of the glycosorb filter or plasmapheresis. However, having said that, I think it's important for all of us to remember that there is nothing safer than an ABO compatible transplant as compared to an ABO incompatible transplant. So it does give you, that is an ABO compatible transplant, a better graft survival. There are less infections, less antibody mediated rejections, and less non-viral infections. However, there is a recent work from Japan that has shown that the survival of ABO compatible and ABO incompatible transplants is almost similar once you have gained adequate experience. And currently, a number of centers have gained adequate experience in ABO incompatible transplants. One of the few things that COVID has done is that it's had a profound impact on renal transplantation. And the impact has been that we've all been forced to relook at our strategies in transplantation. Should we consider agents like basiliximab or ATG? Should we stop the antimetabolite if somebody has COVID? And of course, the emerging scope of telemedicine. So we actually looked at this, and our first paper that we published in Clinical Transplantation, August 2020, was that I think it is best for most developing countries to stop a transplant program, because we felt that you would actually harm more people and benefit very few. However, we were able to sit with the National Organization for Tissue Transplant in India, and we were able, with the Indian Society of Organ Transplantation and the Liver Transplant Society of India, frame guidelines that the government accepted, put on its website, and we were able to frame guidelines at how units could restart a transplant program. We then did look, and this is our first publication that came out, that looked at 250 kidney transplant recipients, a multi-centric study from India, which will be published in Transplantation in January this year. And basically what we found was that if you have a normal creatinine and you get mild or even a little bit of moderate COVID, you will actually not have a bad result. But if you have deranged graft function, you have diabetes, you have obesity, and you get moderate to severe COVID, the disease could be fatal in you. And we actually advise that if you get COVID, the first thing you should do is stop the antimetabolite, continue with the steroids. And the only thing that works in these patients is steroids. And that's about the only message that this paper really gave across. We then looked at our donors. donors who had had COVID, had recovered, and used them as to give their organs to someone they love because they'd been waiting so long, and while waiting and being worked up, they had got COVID. And we looked at how they did if they gave their kidney to someone they loved after having recovered from COVID. And what we found was that if you have recovered from mild COVID, we give you a 10 to 14-day gap, you have no symptoms, and you have two reports that test negative, you are actually an acceptable donor in the era of COVID 19. Moving on to the HLA antibodies, with the advent of Luminex now, which is a very sensitive technology which allows the detection of anti-HLA antibodies, we're able to now get some idea of the MFIs. And if we have what the MFI is, we can actually predict which patient is going to reject and which patient is not going to reject. The other advancement that has occurred is that we do recognize that over the years, cardiovascular disease remains the leading cause of reduced early graft loss and mortality. And therefore, we now suggest strongly that we must look at factors like hypertension, diabetes, cigarette smoking, dyslipidemia, obesity, and must try to control these as much as possible so that the morbidity and mortality that occurs after a transplant is significantly reduced. There is also some work now that if you use the diabetics who have a transplant, you could actually use an SGL2 inhibitor. This is a drug that promotes the passage of glucose in urine. And there is some work, interesting work coming, that this medicine could be used in diabetics who have undergone a transplant, because they have found that though there is an increased risk of genital tract infections and UTI, sugar control is actually better in these patients. So this is an interesting paper that recently came out in 2019, and it seemed to suggest that SGL2 inhibitors are feasible and well tolerated in selected kidney transplant recipients with diabetes. There is interesting work coming out in using kidney machine perfusion strategies. And of course, we have found that if you have a marginal donor, a donor who you're not sure whether to use this kidney or not, using machine perfusion is better for a marginal donor than static cold storage. And it gives you time to allow a better organ assessment pre-implantation and appears to lead to a significant reduction in delayed graft function. There are finally some new drugs that have come. There is belatacept, but despite having very good data, it is currently not used so much because it's just as good or as bad as tacrolimus. There was some evidence about it giving rise to lymphomas. There are some new compounds like CFZF33 under development for kidney transplantation. This is a CD40, CD154 co-stimulation pathway blockade. It's a fully human drug that does not cause B cell depletion. And preliminary data does suggest that it is well tolerated with complete peripheral CD40 receptor occupancy for 28 days. The other drugs that are coming is rituximab, of course, we use, obinutuzumab, which is a second generation anti-CD20 monoclonal antibody. There is bortezomib, tocilizumab, which is now being used, eculizumab, in which the generic formations will now come. And there is a new drug called IDES, which is currently on phase 3 trial, which is basically an endopeptase, which effectively cleaves all human IgG subclass at the hinge region. And therefore, you cannot have a rejection in the first 10 to 12 days of giving this drug. Many groups are currently working on this, and IDES seems to be extremely encouraging because on a sensitized patient, the incidence of rejection the first 10 days is almost negligible. Having said that, the other common thing that we face is chronic active antibody-mediated rejection, which is one of the major causes of long-term graft loss. Tocilizumab is currently being used for this. There are some people who are using data to demonstrate the efficacy of C1q inhibitors for the prevention of a delayed graft function and to lessen the occurrence of chronic active antibody-mediated rejection. Despite several obstacles, and a rather empty pipeline for novel immunosuppressions, there is some development going on and optimization of the current immunosuppressive regimens tailored to the individual patient and driven by biomarkers with optimized drug dosing and better time adapted protocols remains the only option to improving long-term results after renal transplantation. There are some people who say we should work towards reducing steroids, but there are data that says it increases the risk of acute rejection. And therefore, currently, most people feel that one should minimize steroids but not reduce them completely. CNI withdrawals or avoidance or withdrawal cannot be currently recommended, and biomarker-driven minimization of maintenance immunosuppression offers great promise and is being tested in ongoing trials. The other problem that we face in children is the continuous enigma of FSGS, and the therapy of this remains post-transplant FSGS recurrence includes a combination of removal of antibodies through plasmapheresis, using regimens like cyclophosphamide, cyclosporin, tacrolimus, or rituximab. And though there have been a lot of developments finally in the domain of kidney transplants, it is yet to translate into clinically significant GRAS outcomes. With persistent demand for transplantation and changes, smarter ways to use the current supply are needed. The only silver lining is the increasing awareness among the masses about kidney disease and also increasing altruism among kidney donors and their families. Thank you very much for your attention. Thank you.
I thank my dear friend Dr. Sandeep Guleria. He's been a pioneer in evolving newer techniques in kidney transplantation and delivering the best outcomes to the patient in the country. And I also thank our chairperson, Dr. Jacob Thomas. With this, we conclude this session. And at the end, I have a responsibility to give a brief summary, which I would like to put it in just 3 sentences. One is that this whole exercise which has been carried out by GAPIO regarding chronic kidney disease, which what we have learned is that AKI probably still is not as benign as we understand. And our 4 decades of understanding, which Dr. Mehta has very rightly put it, has yet to evolve in its improvement in patients, particularly in long-term outcomes. Similarly, Dr. Shobai, which has brought out something which is a path-breaking kind of innovation, which might change the face of care delivery to chronic kidney disease patients. And what Dr. Sandeep Guleria is delivering is trying to recruit more and more donors so that we can help more patients to have their transplantations. With these 3 key areas where the delivery definitely is related with an outcome of patients, probably would change the whole scenario of patients' outcome and their longevity. I again at the end thank all my 3 learned speakers and 3 chairpersons, and for my audience who has been attending in plentiful numbers I can see in my chat box. I request them, the questions are actually piling up in great numbers. In fact, these numbers may not get answered in 7 days, but I would try that all the people who have been putting up their specific questions with their email should get their answers in time of 7 days. If there's any delay, you'll have to pardon me because the numbers which I'm seeing is rising very in a great enormity. Thank you.